of significant blunt trauma, such as motor accidents or phalangiform height. Fracture in this region range from non-convex to highly convex injury and will vary in prognosis. This injury can be divided into thoraco-lumbar spine can be divided into thoracic spine, thoraco-lumbar injection from T10 to L2, and lumbar spine. The thoracic spine is more rigid of these structures and therefore requires significant force to cause injury, whereas lumbar spine with the thick intervertebral discs and the sagittally orientated passage joints and the lack of the thoracic cage is more mobile. The thoracolumbar junction is the most common region of thoracolumbar fracture due to that a transition point of increased mobility. Conventional radiography, the examination of the thoracic and lumbar spine include anterior, posterior, and lateral view. The upper thoracic spine is difficult to image of the lateral view due to overlying bone and soft tissue of the shoulders. CT, as part of polytraumatic CT protocol, most appropriately image the thoracic spine, as greater force are required to cause the fracture of rigid thoracic cage. Conventional radiography of the thoracic spine has become rare investigation. Soft tissue swelling due to paravertebral hematoma is best demonstrated on anterior posterior view of the thoracic spine, where it causes focal widening of the mediastinum. Alignment in this chest is right, widening of the mediastinum. The same patient in CT, large hematoma. Alignment is assessed on both the anterior posterior and lateral view. There should be equal distance between spinous process and on the anterior posterior view, the spinous process should be central with symmetrical appearance of verticals and vertebral body. In conventional radiography, acute fractures tend to have sharp margins and lucent fracture lines, whereas in all injuries have a smooth cortical margin and sclerosis. A clinical correlation and, if necessary, MRI is a more reliable indicator of age of fracture than conventional radiography. Lumbar vertebra is a common developmental abnormality that should not confuse with acute injury. In the lumbar spine, it most commonly affects the superior end plate of L4. Usually occur during adolescence. The intervertebral disc can be prolapsed entirely, typically occurring without any history of injury. Typical site and well corticated appearance of the bone fragment indicated this is not acute injury. Lumbar vertebra and the lateral X-ray of lumbar spine and the MRIT2 sagittal section CT of the thoracic and lumbar spine should be performed as part of polytraumatic CT protocol that including intravenous contrast agent for assessment of vesical injury. The axial and sagittal and coronal section of sufficient diagnostic quality. Sagittal section of the thoracic spine should include sternum, since this is part of bony ring of the thoracic cage and important for stability of the thoracic fracture. Because of relatively rigid nature of the thoracic spine, injury usually involve bony fractures, CT is therefore very useful for diagnosis or excluding thoracic spine injury. Thoraco-lumbar projection, on the other hand, is a relatively mobile structure and behave more like cervical spine in that purely ligamentous injury can occur without bony fracture. Epidural fat within spinal canal adjacent to ligamentum flavum provide normal line epidural fat, normal, not loose epidural fat due to fracture. Epidural fat within spinal canal adjacent to ligamentum flavum provide the natural soft tissue contrast for assessing the posterior ligaments and anatomical feature which is not present in cervical spine. MRI, the gold standard for assessing purely ligamentous injury. MRI is useful in determining the prognosis and neurological injury. Sagittal sequence should include T1 and T2 weight fat saturated sequence. Short to inversion recovery sequence can be used as alternative to T2 fat saturated sequences provide reliable fat suppression. Bone and soft tissue injury is more clearly demonstrated with fat saturated sequence. Ligamentous disruption without fractures often cause relatively mild odometer's change in soft tissue. These ligamentous injury are best appreciated on T2 weight fat saturated sequence. The gradient echo sequence may be used when neurological injury since these fata demonstrated hemorrhage. Calcification, thoraco-lumbar spine fracture calcification system developed on dense calcification, which widely used. Dense divided vertebral column into 3 vertical parallel columns based on biomechanical study related to stability following traumatic injury. Instability occurring injuries affect 2 contiguous columns, anterior and middle column or middle and posterior column. A 3-column injury is also unstable fracture. 3 columns are anterior column. Anterior column consists of anterior longitudinal ligament and anterior 2/3 of vertebral body and anterior 2/3 of intervertebral disc. Middle column consists of posterior 1/3 of the vertebral body, posterior 1/3 of the intervertebral disc, and posterior longitudinal ligament. Posterior column consists of everything posterior to posterior longitudinal ligament, peticles, facet joint, articular process, ligamentum flavum, neural arch, interconnecting ligament. Fracture type: compression fracture, burst fracture, chance fracture, thoracic spine fracture, dislocation, translation, rotation injury, transverse process fracture, wedge fracture, also known as compression fracture, are hyperflexion injury to the vertebral body result in from axial loading. Most commonly affected anterior aspect of the vertebral body, which the fracture are single column fracture, so it is stable fracture. Appear in the lateral X-ray, chest X-ray, clear. There is wedge fracture. Most commonly, thoraco-lumbar spine fracture. Pathology: typically, these fractures are insufficient fractures secondary to osteoporosis. Some are pathological secondary to focal bone lesion. Some proportion due to trauma in patients with normal underlying show cortical disruption with an impaction of anterior superior endoplate. Anterior endoplate and the posterior vertebral bone remain unaffected. This is result in characteristic wedge appearance. CT of the chest sagittal section appearance of the which fracture anterior and superior compression. MRI, sagittal section of the spine, sagittal section of the lumbar spine, in T2, right? Which fracture affected the superior aspect of the vertebra, and inversion to short to inversion also with fracture. Burst fracture are type of compression fracture related to high injury axial loading spinal trauma that result in disruption of the posterior vertebral body cortex with retropulsion into spinal canal. Most commonly occur at L1 with majority 90% occurring from T9 to L5 vertebra. Two-level burst fractures are much less common than single-level burst fracture. Mechanism: it is a result of high injury compression injury, exhaloding, much like the Jefferson fracture. Typically, they occur following follow from high. Biological feature: loss of the vertebral height on the lateral view, anterior portion of is commonly compressed more than the posterior portion of the vertebral body. The fracture always involve posterior vertebral body cortex, interpendicular widening, bony fragment retropulsion into spinal cord may cause spinal cord contusion, may occur, and it is best assessed by MRI axial and sagittal T2. Anterior fracture of the vertebral body with horizontal fracture through posterior element or destruction of the joints and spinal processes. Widening of the interpendicular distance often suggests burst component. Widening of the facet joints and increased intercostal spacing. Widening of the interspinous space. X-ray anterior posterior view show pedicle, normal pedicle, and this is wide interpendicular distance due to burst component. And the lateral view, X-ray, also show CT, the axial section, burst fracture, anterior posterior cortex destruction, and the sagittal section, the anterior destruct and posterior vertebral body destruction. MRI T2 and burst fracture also caused retropulsion to spinal cord. Transfer fractures, seatbelt fractures, also called, are flexion destruction type injury of spine that extend to involve all three spinal columns. These are unstable injury. Chance fractures are named after George Quentin Chance, British radiologist, who first described it associated with intra-abdominal injury mechanism. They tend to occur from flexion injury of the vertebral body and destruction type injury of posterior element. Location: this fracture most commonly occur about upper lumbar spine. Thoraco-lumbar ejection accounting for 50% of cases, but it may be occur in middle lumbar region and abdominal injury, especially pancreas and duodenal injury that can result in increased morbidity and mortality. Chance of fracture 3 column all destructed, and the MRI and the CT sagittal section, one axial section CT. In MRI also for assessment of the ligamentous injury and cord injury, T1 MRI show chance injury cause compression on the spinal cord. Often posterior bony destruction that were called bony chance fracture. They are relatively easy to identify since bony injury can be seen on conventional radiography and is easily demonstrated by CT. The fracture occurs through one vertebra passing through ventricles and spinal forces at single level. This is a pure bony chance fracture. Posterior ligaments remain intact. These fractures are usually surgically fixed. There is good prognosis since bony injury heals better than ligamentous injury. An inflection destruction injury involving posterior ligamentous structure without posterior bony injury. This is soft tissue chance injury without bony injury present. Such injury can provide diagnostic challenge on conventional radiography or CT, as it can be confused with simple flexion compression injury. Soft tissue chance injury, and the lateral X-ray show normal and not no finding, but show kyphotic deformity. And the other slide, the same patient, sagittal short to invasion recovery MRI with the patient lying supine in MRI unit. There is no spinal deformity, interspinous ligament disruption, and the soft tissue disruption. Other type of fracture, thoracic spine fracture dislocation, severe form of spinal column injuries that occur secondary to high energy trauma. There is vertebral fracture with dislocation of facet joints and or the intervertebral disc space. They are mechanical unstable and are associated with high risk of spinal cord injury. Fracture dislocation and T7, T8, CT, the sagittal section, and in coronal section. CT in a fracture dislocation, there is displacement of vertebral relative to the one below with associated fractures of the vertebral body, vertical lamina, transverse process or spinal process, and the majority of cases, vertebral body translation more than 3.5 millimeters is correlated with higher risk of injury to posterior ligamental complex and greater motor deficits. MRI is useful in assess posterior ligamentous complex injury, traumatic spinal cord injury, spinal cord compression, spinal epidural hematoma. Other type of fracture, a translation rotation spine injury, severe injury characterized by horizontal displacement or rotation of one vertebral body with respect to another. Type of injury is usually severe and involves the posterior ligamentous complex. Radiological feature. Translation rotation spine injury occurs by unilateral or bilateral dislocation facet joint, vertebral body subluxation, translation or rotation. A translation injury is the best seen on lateral radiography or sagittal CT or MRI image, while mediolateral instability is the best seen on coronal image. Posterior longitudinal complex injury, sibling of spinal process with widening of the interspinal space, avulsion fracture of spinal superior or inferior aspects of contiguous spinal process. Common additional findings include transverse process and rib fracture. Translation fracture as appear on the CT. This is sagittal section, this coronal section appearing. There is translation rotation. Transverse process fracture, minor and stable lumbar spine fracture. There is a strong association between transverse process fracture and other traumatic injury. Pathology, transverse process fracture most common occur in upper lumbar spine and are commonly multiple. CT, impact of the transverse process fracture identified on CT, which is may missed on planograph. Other type of fracture, ridged spine fracture. Patient presented with a fracture through a fused spine. Commonest causes of spinal fusion are ankylosing spondylitis and diffuse idiopathic skeletal hyperostosis. When fracture occurs through the fused spine, it always occurs through the full weight of the spine and is highly unstable. Present of osteoporosis in a fused spine results in fracture with minimal history of trauma. Present of gas within the fused spine is indicator of motion and hence a fracture. CT or sagittal of section of the numbers. This is a result of Wickham phenomenon, the same process found in the vertebral disc at motion segment. In the fracture of the ankylosed spine in patient with ankylosing spondylitis, this is sagittal section, CT, sagittal section. There is a fracture through the facet joint. There is fine fracture line through fused facet joint. Other MRI sagittal section short to inversion recovery MRI demonstrated the fracture through full width of spine. The fracture through vertebral body is difficult to define on CT, as the bone is very osteoporotic. It's better in MRI. Spondylolysis is defect in the pars interocularis of the neural arch, portion of a neural arch that connected the superior and inferior articular facets. It is commonly known as pars interocularis defect, or more simply as pars defect. Spondylolysis is represented in 5% of population and higher in adolescent athletics population, more common in men than women. Pathology, spondylolysis is believed to be caused by repeated microtrauma resulting in a stress fracture of pars interocularis. Location, 90% of cases of spondylolysis occur at level of L5 and 10% occur at L4 level. The process may be unilateral or bilateral. Association, 65% of patients with spondylolysis will progress to spondylolisthesis. Scotty dog sign in normal oblique radiography showed Scotty dog. The transverse process like nose, pedicle, eye, and very articular facet, front leg, superior articular facet represented L of Scotty dog. The pars interocularis, portion of the lamina that link between the facet and equivalent to neck of the dog. If the spondylolysis is represent pars interocularis, or the neck of the dog will be have a defect or break. It often looks as if dog has collar around the neck of the Scotty dog. Spondylolysis in CT sagittal section pair of defect and pars interocularis. Spondylolisthesis is slip in the vertebra. X-ray lateral view, the lumbar spine show spondylolisthesis. Spondylolisthesis slip of one vertebra relative to the one below. Spondylolisthesis can occur anywhere, but is the most frequent, particularly when due to spondylolysis at level of L5 S1, and to lesser degree L5, L4, L5. Spondylolysis grade 4 grade 1, grade 2, grade 3, grade 4. As this case, this is grade 2 spondylolisthesis, and the X-ray lateral view show spondylolisthesis grade 2. CT sagittal section also show spondylolisthesis grade 2. Spinal cord injury. MRI provide important prognostic indicator for neurological recovery following spinal cord injury. Position of first fracture either above or below the level of the conus medullaris is important prognostically. Trauma to cord inguinal has much better neurological outcome than spinal cord injury. Mild cord edema has good prognosis for neurological improvement, whereas cord hemorrhage is poor prognostic indicator, and cord transection has worse prognosis. Hematoma within cord less than 4 millimeters in diameter have better neurological outcome than larger hemorrhage. A good anti-echo sequence can be used as more sensitive to presence of hemorrhage. This is MRI T2, and this is a good anti-echo sequence. MRI will show hemorrhage inside the spinal cord. Thank you.
شكرا جزيلا دكتور